So good afternoon, everyone. I'd just like to start it off with the land acknowledgement. And so we respectfully acknowledge that we are situated on the traditional territories and treaty lands, in particular those of the Mississaugas of the New Credit First Nation, as well as the Anishinaabe of the Williams Treaty First Nation, the Huron-Wendat, and the Métis Nations. As ResCon offices are located in Vaughan, we are grateful to have the opportunity to work and live in this territory. Just to keep going onto housekeeping. So as always, we're going to share the slides that have come in. We also share a recording of the link with a post-event summary. We're going to do some questions and answer after Louisa and Michael's presentation, as well as Daniel's. And so in the tab below, and I think everyone knows where it is now, if you can put your questions in the Q&A section instead of the chat box. Some people also send questions to, Amina, Ahid, and I, and that's fine as well. But we will try and get as many questions as we can answered. And so generally during these opening remarks, I try to reflect a bit on where the industry is at and where we've come from. So we've come a long way, obviously, since the pandemic started. And I think these webinars have too. And so thank you to the speakers who are here. Thank you particular to Mike and Joel, who have become regulars. And so I think we're very lucky, and the industry is lucky to have you guys here, quote unquote, as regulars, continuing to provide the expert update that you do. I'm certainly very interested to hear from Daniel and Louisa. I think if you do one more, then I'm gonna have to call you a regular as well. So we're looking forward to that. The goal for these webinars is to make sure that members, people in residential construction, people in infrastructure construction, and across the construction industry stay ahead of the curve as much as possible. And we want to always make sure that we're taking the temperature of the industry. And so a couple observations over the summer. Attitudes towards COVID have relaxed, and we are learning to live with it. I wouldn't say that that's necessarily a bad thing, but in health and safety, we always have to fight and watch against complacency. So I'm sure that's going to be talked about today. Another new thing that we're trying to figure out, and we'll continue to figure out into the fall, is while construction never stopped, other industries did, and we saw a huge increase in work from home. There's projections that you're going to see a migration back to the office. And so we want to figure out what that means when you get a whole bunch of people in a whole bunch of office buildings and how this will be impacted by COVID. Looking ahead to the fall and winter, we can look at Australia because they're coming out of their winter. And so what does, the fall and winter and cold season bring for COVID, and how will that impact it? Today's speaker, and I think pretty much everybody knows everybody, Daniel will need to be introduced, but we've got the Chief Prevention Officer, we've got Mike and Louisa for a legal update, and Daniel's going to provide a medical update. These presentations are designed to answer many of the key questions. You guys can ask your other questions if we miss anything. But one thing that I'm a big supporter on, ResCon is a big supporter on, and I know a lot of members and people in construction industry have done a tremendous amount of work on, is vaccinations. And so it is important to note that getting vaccinated, and I would say every vaccine counts, including your fourth dose, is important, and it's a great way to stay safe and stay out of hospitals, which I think is one of the main goals that we have with respect to COVID. I also have the pleasure of introducing our first speaker, and that's Dr. Joel Moody, who is the Chief Prevention Officer. Amina and Ahid and his staff, sent a lovely bio, but I don't think I need that anymore because I have really enjoyed getting to know him and the work that he's done. So he's been in the position long enough that we in construction know who he is. He's earned our trust and our respect, and we really view him as a partner in keeping workers safe. And so we're thankful for that partnership. He did join CPO from the Electrical Safety Authority, and he was on the senior leadership team, and he's done a whole bunch of incredible work there. But he's been introduced at enough events that I'm not going to beleaguer it or go on and on. He is turning me back into a little bit of a Duke fan. He's got some great photos and different things. So if you ever get some one-on-one time, I would advise you to see those. But without further ado, please let me turn it over to the Chief Prevention Officer, Dr. Joel Moody.
Andrew, thank you so much. And to the other members of ResCon, thank you so much for having me today. Do want to share my screen with you. Do you have a couple of slides that I'd just like to present to the group at this time? But, as we, have gone through it, I want to remind people that, after 2.5 years, there have been many sacrifices in the economy and for the people in Ontario that you've made over this period. But we're slowly continuing to get back to normal. Andrew alluded to individuals in office spaces returning back to those workplaces. Within the construction industry, you never left. And so, continuing to be, that steadfast group that is getting that are getting things done for the province. Definitely want to thank you. Most of the public health measures have been lifted, and Dr. Warshafsky will probably talk a little bit later about some of those things. Masking still within the ability of the employer and with the employee, because we know that the COVID virus hasn't left us. We are still seeing some cases. We're still seeing those opportunities. So we do encourage everyone to still be vigilant, because at the end of the day, we have to not only keep ourselves safe, but our families, our coworkers, our friends, our community. How do we do so in the best way that everyone is health and safety? So here at the Ministry of Labor, Training, Immigration, and Skills Development, still sometimes getting the name incorrect because we've added immigration. Safety is our #1 priority. And even, with or without COVID, health and safety of our workers is paramount. And so definitely reminding all that as an employer, employee, there are obligations under the Occupational Health and Safety Act about protecting workers and hazards in the workplace. And COVID is no different. So I'd like to just present some slides about where are we within the context of our planning, especially for the fall. So, one of the things that we do talk about is the fall is going to be maybe a little bit different. There are going to be some unique conditions that could apply to us. And so, the COVID, the flu season, general cold, how are all of those now coming into play with respect to not only ourselves, but what about if you have young individuals, young kids at your house, or those that have immunocompromised systems? What does that mean? And we do know that the Ministry of Health is working about different scenarios and planning. And so the Ministry of MLITSD, we are working in lockstep with our colleagues at the Ministry of Health and as well as Public Health Ontario, such that any messages that are coming from the Chief Medical Officer of Health through our colleagues there, we're going to be able to amplify. We're going to be able to get that information to you as soon as we can in very plain language. And why is that important? Well, we are looking at other jurisdictions, and maybe we'll talk about Australia a little bit later about what's happening there, and then how is that being used to look at the health trends that possibly are impacting us here in Ontario. And so at the end of the day, I want to always remind our construction sector, be proactive with your planning, because that is the best way to efficiently respond, not only to COVID in the fall, but the other respiratory type of infections as well. So what are we doing? So what is government doing? So right now, we would say, within government, we're assessing the strength of all sectors. And right now, we would say that's a very strong finding. But we do know that we will have to take potential actions based upon, what it looks like with, cases, the waves that are coming. And so how do we do that? So we want to make a way that, health system capacity always in place and prioritized. That is one of the very first principles that we're looking at. Secondarily to what I just said, how are we making sure that we're providing timely advice and guidance? So as soon as we're able to get information from our colleagues at health, the ministry works together, and then how do we use and work with our HSAs, groups such as ResCon, in order to help provide the message to you in a timely fashion such that you can also make your decisions. Care sectors, testing, vaccines, therapeutics, all of those aspects are important tools within the arsenal, but we have to ensure that, if you are able, definitely make sure that you're getting your vaccines at great times. And Dr. Warshafsky will probably talk to you more about what that means. Accessibility to resources. This is where when we look at some of our sectors around, filtration, HEPA filters, high-risk settings, all of these are workplaces as well that we want to ensure that we're doing the best in order to minimize risk. But we also talk about planning, and I keep coming back to that word. The whole concept is getting to the group early such that you can do the appropriate planning based upon your risk profile. One of the important things we talk from the occupational health and safety standpoint is what are the hazards that exist, and have you done that risk assessment? So using some of the tools that you've used earlier, such as the pandemic planning tool that we have available on the website, these are things that can help. And as we talk about the resources that are available, these slides will be provided, but the health and safety guidance are resources that we have. Our health and safety associations continue to be great resources to help provide those resources for you. And as well as there's a document from WSPS about 9 steps to get ready for the fall. The masking guidance, we've updated with very practical information that you can use to help with your decision about type and fit of mask and filtration that can work. One of the things that the ministry has also been looking at is the worker income protection benefit. It was supposed to end July 2022, but it has been extended to March 31st, 2023. So that is a program that's still available. And as always, if there are any concerns, please get in touch with the ministry. Our inspectors are there to help answer any questions, especially if there are concerns about enforcement activities as well. As the regulator, we have to remind ourselves that it is our responsibility to assist, and we will do so. And the WSIB, another great partner that we also are working with for those businesses about 1 to 99. What are opportunities to help continuing to recover from the pandemic? So doubling the rebates that they've given towards your safety plans and systems. So those are the updates that I would just wanted to be able to provide to the group now. And definitely, Andrew, I'll still stay on to help answer any questions that may come our way. So thank you so much, everyone.
Thanks, Dr. Moody, for providing those remarks. It wasn't in your bio, but one thing that Dr. Moody and I share is that we're both graduates of George Washington University, which is certainly not a common thing for people up in north of the border. So yeah, go Colonials, as they say. Anyways, our next speakers are Mike Sherrard and Louisa Vilknovich of Sherrard Coos. Michael is recognized as one of Canada's leading employment and labor lawyers. His clients are national, international, public, and private, and operate in a wide range of industries and sectors. Acclaimed for his strategic excellence and outstanding client service, Michael draws praise for satisfying the needs of even the most demanding clients and a specialist knowledge of union contract and negotiation issues. He's also the former chair of the National Labor and Employment Law section of the Canadian Bar Association and the Labor and Employment Law section of the Ontario Bar Association. He was also recently appointed as chair of the Board of Directors of Skilled Trades Ontario. Welcome, Michael. Louisa Vilknovich advises, represents, and advocates for employers in many areas of employment and labor law. She began her career with Sherrard Coos as a law student, during which time she participated in a secondment with the Ontario Labor Relations Board. Louisa is bilingual in English and Russian. And she's a member of the Law Society of Ontario, the Canadian Bar Association, the Ontario Bar Association, and Labor and Employment, Civil Litigation, Constitutional, Civil Liberties, and Human Rights, Workers' Comp, and Young Lawyers. So a lot of areas of expertise that you have, Louisa. Anyways, welcome, Louisa and Michael. Thank you.
Thank you. And we're going to share the presentation and share a screen as well. Let me just see if I can get that going. 2 secs. Okay, so Louise and I are going to try to take you through in this next short period of time where we've been or where we were, where we think we are right now as we speak. And then we're going to try to do a little bit of prediction along with Dr. Moody's comments that we've just heard of what we think may show up here in the fall as we move forward. So in terms of where we were, your organization and certainly your sector, I think most of the time we saw you as the leaders during COVID. So when COVID touched our shores in March of 2020, and people started to go through an evolution of what this was going to mean for us, the construction sector clearly took a lead, and your site-based efforts probably were key to seeing all levels of government embrace the sector and see the sector remain open while many sectors were closed, certainly through the province of Ontario, let alone in other parts of the country. We've also seen a number of grievances that are now maturing into arbitration, and Louise is going to spend some time taking us through what's occurring. But the key tests started early on. Everybody will remember an Ellis Don case where there was some challenges around their testing protocols down at the Well Project. We'll talk about those just briefly. That was really focused on their testing policies as opposed to what many of you now have in place, and that was the urging to have your workers get their vaccinations. And we're going to talk a little bit about your definitions in the vaccination policies that many of you put out. Some of those vaccination policies just talked about the 2 vaccinations. And you'll remember Andrew's, one of his opening remarks talked about the boosters, and we'll try to make some comments about that as we get ready to go into the fall. But the cases are out there, and there's many of them still rolling. So we're still in the middle of litigation around these policies. And then not that recent. I mean, I think when we talk about Omicron, we probably go back all the way to January of 2022 in terms of when that variant was first identified. And I think I'd call it subvariants, subject to a better medical term for it. I think this is what the early decisions, and remember the very first one out of the gate was Paragon. And we're going to try to, you can grab these slides later, but because we're going to go through them fairly quickly, but we wanted to give you as many cases in case you're referring to case law later on or want to look in more depth. Paragon was the very first case out of the gate. It was really unique though, because it had particular language in the collective agreement. And so many of us distinguished it from how an arbitrator should look at a vaccination or test. And if you didn't do those things, you might end up in an unpaid leave. Then the Electrical Safety Authority, the first case that was written by arbitrator Stout. And he was very clear in his reasoning, and it was helpful because he said, in this current situation, I don't see a policy that says vaccinate or else you end up on an unpaid leave with the potential for termination to be reasonable. He was clear though, he said, in these circumstances, in his case, his first decision was really early on in the process. And I think what we've seen since is an evolution into, I think, not to steal Louise's thunder, but a lot of the policies that said, demonstrate to us that you've complied with the vaccination protocol that we've asked you to in our policy, and failure to disclose to us that kind of activity that you've actually been vaccinated will leave us with no choice but to put you on an unpaid leave. That's, I think, for the most part, been found to be reasonable, but we'll hear more about that. The OPG case was all about testing and who should pay not only for the testing kits themselves, but who should pay for the time it takes to test. And arbitrator John Murray made some very good comments in that I think have been followed for general purposes. The next case in Hamilton was a case where the employer that was involved was actually on some federal lands. And so because part of their properties were covered by federal jurisdiction, there was some interesting comment made about, well, if the federal authorities have come out and argued for the enforcement of vaccination policies, do you as the person on their land actually have to comply? And many of us had to figure those things out. And the analogy was, if I had to go to a third party's site, do I have to comply with that third party's obligations? And there's been lots of law around that. Ellis Don I talked about already. And then the Unilever case that's unreported, but still worth taking a look at, was that mandatory testing. Remember, testing, not vaccination. So this is all where we were. Now we're going to move into where we think we are today. And I think Louisa's probably going to comment fairly significantly on vaccination policies as opposed to the rapid antigen testing and the testing policies. And I'll move these slides as you want, Louisa.
Perfect, thank you. So absolutely, since we last spoke to you in January of this year, there's definitely been a lot more guidance that's come out, specifically with respect to unionized workplaces and consequences for non-compliance with a vaccination policy. So we're going to do a very kind of brief, high-level overview of those decisions because there have been quite a few. So we're going to do that in a minute, but just to kind of put on your radar and highlight what I would say are two trends just to make note of at the outset. The first being that you'll recall just a moment ago in that previous slide, we looked at all those decisions, and really there were only two that contemplated being put on an unpaid leave for non-compliance with the policy. And you saw that they split ways. So that was Electrical Safety Authority that went one way, and then Bunge that of course said, yes, it's reasonable to have an unpaid leave. So what we're seeing now as a general trend is that most decisions are echoing Bunge, and that they're generally finding that a vaccinate or unpaid leave policy is reasonable. And then you'll also note that there's been some commentary echoed throughout, specifically with respect to, suitable alternatives for vaccination and whether or not there's something more, to put it in the words of the case law a bit, minimally impairing as compared to vaccination or minimally intrusive with respect to kind of an employee's physical integrity. And so that was one of the pieces of analysis that a lot of decision makers were considering. And so what we're hearing now is that rapid antigen testing, where it was once kind of proposed as the better alternative, there is now clear case law that's saying, it's not more effective with respect to reducing COVID-related risks, and that vaccination is still the suitable alternative there. So we're going to take you through the first batch of cases. I'll just wait for Mike to take us to that slide. So again, this is just the first batch. We have a couple more slides here. So again, I'll be doing a very broad strokes overview of this, but you'll see that for the most part, most of these decisions have landed on the policies being reasonable. The exception, of course, being Chartwell that seemed to part ways. And there are a couple of reasons for why, if you look at the decision and the analysis, why it went that way. So just a couple of things to twofold, I would say, comments to note. The first being that the collective agreement contained a very specific provision in it. And that provision basically said that any existing rights that were greater benefits should be continued. And so it was viewed as the policy is in conflict with the collective agreement. And then on top of that as well, the policy seemed to kind of automatically contemplate discharge for non-compliance. And so there was clear commentary there that, if it's automatic and it's not considering individual exceptions or circumstances, then perhaps that's not a suitable consequence for non-compliance. So those are just two things to note there. With Rivera, actually, it specifically picked up on the commentary from Chartwell, distinguished it and said, as long as termination isn't automatic, the policy is likely to be found reasonable. Just one more note briefly on this slide with respect to a lexicon, which was the first decision there that came out in February. That decision actually had some commentary that came out and said, the state of the pandemic is so fluid and so dynamic that what was, once appropriate may not be appropriate now. And so that's just something to keep in mind, because even though the case law has developed, that commentary is still very much at play and something to keep at the back of your mind as we keep going. So with this next batch of cases, we're going to look at specifically the commentary in Electra. So again, you'll see most of these are reasonable, with the exception of FCA. But just before we touch on FCA, Electra specifically introduces this concept. So in this decision, the union introduced evidence that said vaccination might not be so effective anymore in light of Omicron. And despite having considered this evidence, the arbitrator ultimately concluded that unvaccinated individuals still do pose a risk to vaccinated individuals in areas of congregation. There was some kind of contemplation of what that might look like if you're in an outdoor setting, which starts to sound very familiar with respect to Ellis Dawn and what we heard way back when we started looking through these cases, about the idea that when you're outdoors, transmission might not be as likely. So that is still somewhat echoed in the case law. FCA picks up on this idea of there being a conflict in the medical literature. And so this decision was really decided on the basis of medical evidence that said that, vaccination isn't a suitable means of addressing the risks posed by COVID anymore, given the difficulties associated with Omicron. And so perhaps we'll hear about that a little bit later on from Dr. Warshafsky. So with respect to the next batch of decisions, I'll just briefly note here, again, both landing in favor of the reasonableness of the policy. Wilfrid Laurier specifically comments on FCA, the decision that found the policy was unreasonable, and it distinguishes it. And the way that the arbitrator distinguished FCA was by saying the definition of fully vaccinated in the policy wasn't limited to, 2 doses. It was specifically defined and tied to ongoing public health announcements and periodic reviews of the policy. And so because of that, that's something helpful to keep in mind with respect to, our conversations today around boosters and things of that nature as well. The idea of an adaptable policy that contemplates what's happening in the medicine and keeping up to date. So that's the labor side of things. The employment side of things, or the non-unionized workplaces, there hasn't really been much guidance, which is crazy to say since we started with this whole pandemic. There's really not much that's to be said that's out there. I think one decision in particular that we want to comment on is Taylor and Hanley Hospitality. And just to back up, a couple of steps, some of you might recall in May of 2020, the Employment Standards Act was amended with a new regulation that basically allowed employers to put employees on essentially like a temporary leave of absence due to COVID, and to help them with that form of relief, and without that constituting a termination. And so one of the arguments that we've heard from the plaintiff side is that, well, that constitutes termination, that constitutes a constructive dismissal at law. And so Taylor and Hanley was something that had a lot of us on the management side of the bar, waiting with excitement, because we were really hoping to see some clarity from the Court of Appeal on whether or not that's actually the case, whether or not, a leave under idle would amount to constructive dismissal at common law. Unfortunately, the court kind of sidestepped that issue, and we ultimately didn't land one way or another. So we're still waiting on further clarification from the law on that piece. No wrongful dismissals yet really dealing with non-compliance with COVID policies either to remark on. But at the Ontario Labour Relations Board, in the decision you see below there on the slide, Jennifer Mason, there an employee was terminated for failing to comply with the mandatory vaccination policy. They claimed that that was reprisal under the Occupational Health and Safety Act. And so just to kind of briefly walk you through, the idea is if you raise a right under the Occupational Health and Safety Act and you're found to be subject to negative repercussions as a result of having raised that right, it would amount to reprisal. Ultimately, the board found there was no nexus between being terminated for failure to comply with the vaccination policy and the Occupational Health and Safety Act. So at least we know with that respect, we have some commentary on what that might look like at the board. And then looking at what's next, just generally, what we're left with is this concern that, again, there's a waning effect of vaccination when we're looking at Omicron. And so really, the concern on our end is this trend that the commentary from the FCA decision we just briefly spoke about is going to continue being repeated throughout the cases. And I think some of this will depend on the medical literature, how that develops, and specifically the development of vaccines, perhaps the efficacy of boosters in addressing Omicron. And again, I'll leave that to Dr. Warshafsky for his insights with respect to the medicine there. And then, of course, we've seen right now at the moment, provincial restrictions have lifted, federal restrictions have lifted. Many of us are familiar since March 21st of this year on construction sites, masking, for instance, is no longer required. So we're seeing a lot of walking back of directives. And so I think that's raising a lot of questions for employers as to what's next. what do we need to be doing? What should we put on our radar? What's to look forward to? And I think we've tried to anticipate some of that, and I'll turn it back to Mike to address next steps.
Great, thank you, Louisa. So next steps for a lot of us, construction sites, many of us have never left those sites. So when you see RTW or return to work and ensuing absenteeism, some of that's a quandary because many of the sites have continued on, but we are seeing employers when they're trying to figure out, and so I'm thinking about now your office sites your offices as opposed to just on the construction site. But what you really want to be thinking about as we go into the fall is Louisa's comment as opposed to Dr. Moody's comment. Compare them. Masking mandates have disappeared. Dr. Moody's slide still talks about masking. So we want to think a little bit about what's the law requiring of us versus what are some of those best practices. So when you look at absenteeism, and many of us, I think, are suffering from high absenteeism rates that are coming from people who have had COVID due to Omicron, as an example, or are a close contact and they're still isolating as we would want them to isolate. We're seeing a lot. We're still seeing a lot. And I think many of us anecdotally might say the following. In 2021, I knew 2 or 3 people who got COVID. In the fall now, as we go into the end of August, I know so many people, I can't keep track anymore of those who have suffered from COVID due to having caught it through the Omicron variant. Now, the lucky part is most of those folks that I've interacted with had what I'll call COVID light, for lack of a medical term, and haven't suffered any serious medical consequences. So when we look at where we're moving, August into September, kids are going back to school. I think there's going to be some spikes on COVID that will come out of some of the schools. I think is inevitable. They're going to get to their parents next, and therefore absenteeism is going to continue to be a problem. When absenteeism is a problem, I think we need to go back and look at what are those best risk management practices that this whole industry really led on a year ago or more than a year ago now. And we need to go back and think no more complacency. It's time to get back up and check our protocols. And what I mean by that is if you've got a vaccination policy, for example, that only refers to the 2 vaccinations, consider Louisa's comment that comes out of one of the cases that says, maybe I need to amend my definition of what to be vaccinated actually means to include the boosters. All of this, you might say, well, let's pause. We're hearing from the lawyers right now. Let's hear what the doctor says about that. But I'm betting the doctor we're about to hear from, going way out on a limb here, but might be a fan of boosters. And so we want to point to government health authorities with respect to potentially updating a policy if you don't already have that updated. I want really clear expectations with all of my people. If I'm going to continue to mask mandate, even if the government's not requiring it, not only do I want to talk to people about it, I want to enforce it. So if you were sitting in our office as an example today and Louisa came in to visit me, you would see both of us immediately put on masks, right? So when we're wandering around an office, we're masking. If I'm on public transit, many of us want to also think about, do we communicate with our employees around advice and guidance, maybe not requirements, but advice and guidance about how they travel and what they do when they're traveling, and all that helpful advice that many of you led on with respect to something as simple as hand washing versus hygiene practices versus distancing all the way through back to masking. If I'm going to change any of my expectations as I try to potentially bring more people back to work in an office setting, I want to give them reasonable notice of what my expectations are. So that reasonable notice isn't like 2 days. Reasonable notice is a fair period of time so people can reorganize their lives. If, for example, for the last 12 months, they've had the luxury of working from home. There's going to be hybrid situations, and all of you have been engaged in discussions around, well, what does the workplace look like for those of us who don't have to be on site? And those hybrid discussions have been everything from 1 day a week to 4 days a week, to some employers saying, I want everybody back and I want everybody back full time. I put in brackets here, think about equities in your workforce. It doesn't mean everybody has to do exactly the same thing, but we want to have the considerations around, if I have everybody on site, what do I need in my office to make sure that I'm still supporting everybody on site? And this, the last bullet isn't fancy. This isn't going away anytime soon. You heard comments in the introduction, and then comments from Dr. Moody, the references to taking a look at Australia. And the only thing I caught today was, I think the Globe and Mail, today's Wednesday Globe and Mail, it's the first time I've picked up a newspaper and went front to back and didn't see a COVID article. I'm not sure I can say that's what I expect to see happen for us all as we move into the fall and we see that confluence of colds, flus, and more COVID, unfortunately. Case law, the evolution of the case law is going to continue. People are going to continue to challenge the reasonableness of the policy. That doesn't mean we as employers should be shying away, because we know, rooted in health and safety obligations, we need to take every precaution reasonable in the circumstances. So I may want to be aware of what the government says are its view of the circumstances as a standard that I can lean on. And I can't wait, frankly, to hear from our doctor coming up next, because his views are really critical to help support the kind of policy I want to continue to enforce and or encourage in my workplace. We still have the desire to have people to be vaccinated, and that means, in our definition, including boosters. And I think there was a more fluid way to say that in terms of consistent with what public health is recommending, I think I heard earlier. There are some medical science articles out there about the waning effect of the vaccination as it relates to Omicron, but there is evidence that I think meets that worry and trumps it when we start talking about, but if you're taking boosters, or if we see a vaccination that is more targeted, as we're all listening to in the news for the fall, I think those kind of moves are going to meet the argument that policies aren't reasonable because of the waning impact of a vaccination. I think it's not controversial to say we know vaccinations have reduced the health consequences for the majority of our population. And to Louise's point, remember, she said testing was thought of to be really good, but it is absolutely clear the best protection as against the health consequences of COVID really is the vaccination, and those vaccination protocols of having more than just simply the 2 vaccinations. A bellwether, right? We've heard the federal government securing millions more doses for the fall. And so I've said this already, take a look at your policies, consider updating them if they're not already clear with respect to the desire to have people include in their protocols the booster. It's now clearly available. And then again, let's stay in tune with the medical guidance. I think one of the best things the Ontario government did with its Ontario Science Table, they continually updated, and they helped a lot of us to understand what are those standards that we should be following. And I think those will put us in good stead. And then finally, whether you were in Ontario or any other part of the country, if you were in the US, this standard's still the same, or you were federally regulated. And I know most of us on this call are provincially regulated in construction, but we live every day with the concept that we will take every precaution reasonable in the circumstances to protect our workers and make sure they go home safe each and every day. So whether I'm looking at the act or I'm looking at the values of a company, that's the phrase that helps us look at, do we continue to require vaccinations? And we are loud, clear proponents. Maintain your policies. It is not yet time to, in my words, let your guard down and say all of a sudden we're going to disband the vaccination policy where we had it in place and we were encouraging people. Now we're going to wipe it out. It's not yet time to do that from our perspective. People are going to challenge you, but you'll fall on the right side, we think. Remember that these policies, just to make a comment too, that I'm not sure we've covered today, there are still exemptions in these policies. We all have exemptions that tie back to the provincial human rights code. We know primarily they are medical and or religious exemptions. What we didn't comment on today is that there actually have been some cases looking at employees who have sought to be exempted from a vaccination policy on the basis of a religious exemption. And there is good case law out there. If you get one of those, we really recommend you take a look at those cases, because they're looking at whether the individual who is claiming an exemption has a sincerely held belief. And frankly, I'd say that's more elastic than we might normally give it credit for when you actually read these decisions. What a sincerely held belief is really important for you when you're looking at exemptions to the policy. And then remote workforce assessments. I might blow this up and go back to Dr. Moody's comment. Why not go back and do another risk assessment? How long has it been since you did a risk assessment, whether that be at your site or a new site or in your office? Why not go back and do another risk assessment based upon maybe what you've heard today, but also what you're about to hear today from our doctor, who I think at this point, subject to us wanting to take questions, I think, Amina, we might turn it over a bit early unless you want us to take questions right now, which we're happy to do as well. And I'm going to stop the screen sharing if that's okay.
Yeah, I mean, we have a couple of questions coming in, so maybe if that's fine, just maybe 2 or 3. That's good with you all. So noting that, like what you were saying about how it's not time to get rid of policies, can you just remind people, if someone doesn't want to comply with the policy, what are their options as an employer?
So the first option that most of us have had some success with is to take them through some education about the pros and cons of the vaccination. That's as a first step, because sometimes it's simply somebody not understanding the pros and cons. And I think we as employers have an obligation to assist with that. And there have been very good materials, and many arbitrators have commented on the enforceability of a policy by looking at what have you done before you simply, for example, had a negative employment consequence enacted. So that's the first place we start. If that puts a person in a place where they go and get their first vaccination, we know there's also a gap between first vaccination and second vaccination in what the doctors are telling us. And so you might have somebody who's gotten one vaccination but is still offside on your policy, but they've scheduled in a timely manner the second vaccination. And I think that also gives an employer some elasticity around what they do with that person. If at the end of the day, the next one is, I don't want to get the vaccination, and it's based upon a medical issue or a religious issue, then we want to work through the questions to better understand what is the medical issue. Does it actually qualify as something that should allow somebody to be exempted, or a religious, quote, a sincerely held belief? Does that actually qualify as an exemption? In those two issues, if they do qualify for the exemption, then the employer wants to look to whether there's an ability to accommodate them to the point of undue hardship. If we move to the fourth part, there are no exemptions. It's my personal preference. I don't want to get vaccinated. The majority of policies that I've seen so far that have been enforceable have said, at that point, therefore, I'm going to put you on an unpaid leave at this point, because my policy still says, if you're not vaccinated, that's the consequence. When people go to challenge these policies, they look for things like, is the policy a reasonable balance between the person's desire for personal integrity, or privacy, but integrity, I think bodily integrity, is how we would phrase it, as against the need of the employer. What is that need? That need for the employer goes back to taking every precaution reasonable in the circumstances. So it's that balancing act. But I think most of us have found we're going to be successful if we go through those 4 steps I've talked about, getting to an unpaid leave of absence. I think the open question becomes, are you able ultimately to terminate somebody for just cause? And I think that question, unfortunately, I think is still wide open. I think it'll be very difficult for anybody to give a black and white answer, as one would say. I don't think that will work. So hopefully, Amina, that addresses the question.
And earlier you mentioned like expectations. So are you, and by that you mean that's in my policy, an expectation. And so like, for example, like maybe you haven't updated your policy in a while because COVID, things are opening up and you felt like you didn't feel the need to, but for example, you had a conversation with a small part of your team, maybe not the entire office, that we were going to agree to wear masks, like you were saying, and maybe in the same room. Can you still have that expectation, not related to vaccinations, related to maybe screening or wearing masks or whatever, without a policy?
I think you could do it, but I still think it's a best practice to have a policy so that we can look at, like, the case that actually frames a lot of this analysis is referred to as KVP. And what KVP says in a unionized environment, it says the policy should not be inconsistent with the collective agreement. So we want to look at what the provisions are in the collective agreement. It also says, has it been clearly communicated, and have the consequences of failure to follow the policy been clearly communicated? So those are only a couple of them, but those are really important. And so I think it's a best practice for every employer, if possible. I'm not talking about a 10-page document. This can be a short document that sets out expectations. And remember on that slide, Amina, the other thing we said in it is give people notice. Give them an opportunity to get ready to comply with what you're going to ask of them. Use masking, to your point. Whether a government mandates masking or not doesn't, from our perspective, negate an employer's ability to continue to require masking. And so remember that sometimes the Health and Safety Act is that minimum standard, but many of the construction clients on this call for sure go way beyond simply what the Health and Safety Act mandates or any of the regs. So again, I think you can do it. I do prefer a policy as opposed to simply a conversation in a department.
And you also mentioned like religious exemptions regarding the vaccine. I think there's been a lot more conversations than we've ever had about medical privacy, whether it's related to COVID vaccine or just really any vaccines now that have been traditionally mandatory and widely accepted. And yeah, where does medical privacy sit in terms of like exemptions?
Louisa, do you want to jump in? We can probably banter on this one back and forth, frankly, in terms of that balance to be struck.
Absolutely, yeah. So, I mean, from our end, how we've seen it communicated, as you heard Mike mention earlier, the KVP principles. One of the last kind of items that you have to look at when you're addressing the reasonableness of a policy is how that policy weighs, the health and safety concerns in the workplace versus an individual's right to things such as privacy, bodily integrity, right? All of those factors. So I would say that it weighs in that analysis. And in large part, I think most arbitrators have still weighed in favor of health and safety of the collective in the workplace, kind of weighing out in favor. And we've certainly heard similar commentary from injunction decisions as well. So that's just a little bit more on the employment context. So again, non-union workplaces with respect to, employees trying to hit pause on an employer's ability to roll out a vaccination policy. And certainly in those decisions, we hear the same thing being echoed, that the rights of the collective to the health and safety in a workplace seems to outweigh the concerns that naturally and validly arise with respect to privacy.
And then there's a question that just came in. Due to the fluidity of advice at times, is it reasonable to have our policy suggest that employees follow the guidance if they receive when they complete the Ontario government COVID-19 self-assessment? There's guidance for masking, close contacts, and isolation via the government's COVID-19 assessment.
Yeah, at least my vote would be yes, that's very reasonable. I mean, we're always hunting for a standard if we can to align what our conduct will be or our expectations will be. And I think trying to keep abreast of the up-to-date medical information is really what we need to all do. And that does mean we're going to, and the question puts it the right way, right? We are in a fluid environment. It's going to continue. And I think in that fluid environment, we don't know what that next VOC might be and how severe it could or could not be as we move into the fall. And so I think it's incumbent upon all of us to keep looking at this, even on a weekly basis, peer conversations as well. Whether you call a ResCon or any other association, I think the more we talk to each other about best practice, the better off we're going to be. Because at the end of the day, it's still all about, can we keep making sure everybody goes home safe every day? Can we keep our sites open? Can we keep the industry? And remember, this industry, I think, led the way on even some innovative practices in terms of how we keep people safe and keep the sites open. So I think kudos to the construction industry, and we hope you will watch the fluid situation, because the doctor who's going to join us shortly is going to talk about transmission. What's the medical science around transmission? What do we know now that we didn't know 24 months ago? So transmission is going to pop in here as well.
And then maybe this will be the last question. So WSIB still recognizes COVID-19 as a workplace injury. What should an employer do if a worker claims they were infected within a workplace setting?
Maybe we can banter again, Louisa, jump in with me, but I still, while people aren't requiring, at least recently, aren't requiring contact tracing, I still think if we're trying to keep high attendance, it's incumbent upon us to try to sort through, where did that individual work? Remember, right back, Amina, to your comment about balanced as against individual privacy, but I still want to do some contact tracing to understand whether or not there's some things I can do to at least hopefully prevent the spread in the workplace, so that all of a sudden I move now from an individual to an outbreak. So I do want to look at that, because you're right, as the question starts with, right? WSIB still recognizes it, but just like an injury or any other hazard, I want to go back and look at, can I understand root cause? Because not always is it the workplace, but I do want to try to understand it.
That was exactly my point that I wanted to raise.
Perfect. So I guess we'll move on, and I'll give the mic over to Ahad. Thank you.
Thank you.
Thank you, Mike and Louisa. So if you guys have been attending any of our events, you're certainly going to be very familiar with Mike and Louisa, as Andrew mentioned at the beginning. We did also work with Mike on a COVID policy template. ResCon created a COVID policy template. We'll be happy to share that with you in the post-event summary. And again, the slides will be there too. Thank you again. And it's always very beneficial to have you guys with us. So as always, we can never call it a COVID webinar without having a health update. So next we'll be hearing from Dr. Daniel Warshafsky. Dr. Warshafsky is an Associate Chief Medical Officer of Health in the Ministry of Health for Ontario. He has led a variety of portfolios over the course of COVID-19 pandemic, including case and contact management, testing, sports and schools. Currently, he leads work on COVID-19 therapeutics and vaccination. He is an assistant professor at the Queen's University Department of Family and Community Medicine and adjunct lecturer at the University of Toronto Dalalana School of Public Health. We're happy to have you with us. Dr. Warshafsky, the floor is yours.
Great, thanks so much for having me. So I can start off with a couple of slides that I have, if I can figure out how to share the screen. But I was going to begin with well, I can't figure out how to share the screen. I think this one. There we go. I just wanted to start off with, and hopefully everybody can see, a bit of a summary of where we're at with COVID-19 right now, and what we might expect for the fall. And I'm happy to speak to, a lot of points about vaccination treatments and what we're seeing now in terms of transmission. So can everybody see the screen?
Yeah.
Okay, great. So this is a summary just of what's happened since Omicron. Obviously, it's come up already. With each new variant, things change significantly. We went from original strain to Alpha. We saw increases in cases. When we got to the Delta variant, we ended up seeing pretty significant increases in severity. But Omicron is kind of a new face of COVID-19, and really following along what we see for Omicron is most important. So the big things about Omicron are that it was significantly more transmissible than the previous variants that we had. 2 to 3 times more transmissible than even just Delta had been before it. So as you can see here, December and January of last year is when we had that big spike where we first got initial Omicron introduction into Ontario. That led to huge numbers of cases. The numbers of cases that you see on the graph here are certainly underestimates, because we know that as it went on, people were much less likely to get testing unless they were high risk and needing treatment. But I think this gives a really good sense of what we're seeing in terms of the trends of COVID-19 transmission. So we had that initial enormous spike of Omicron where big chunks of Ontario were infected. Probably in the range of 50% of individuals in Ontario had Omicron during that first wave when we go back and look at the data we've seen. What's happened since then is on a roughly 90-day cycle that you can see here, we've had additional waves. So we've gone from that initial wave 5 now through 6 and 7 of Omicron subvariants. So these are just variations on the initial Omicron that have been either, again, slightly more transmissible than the previous version or slightly better at evading the immune response that we have seen previously. So the wave 6 was driven primarily by BA2 in Ontario, and the wave that we're kind of just coming out of now, as you can see on the graph, was driven primarily by BA5 in Ontario. That cycle is something that we're watching closely to see if we can kind of predict what we're going to have in the fall. But the other important thing to note is that the total case numbers have been significantly lower each time as we go down from wave to wave, which is what's expected overall when we have a pandemic. We started with no immunity whatsoever in the population, so anybody who got exposed is going to get it. Once we had that initial big bump where basically most people ended up getting Omicron, we now have, in addition to the immunity from vaccination, natural immunity on top, and that hybrid immunity has been shown to be most effective at protecting against COVID-19. So this pattern of really large wave followed by smaller and smaller waves going forward is something we'd expect, particularly over the summer, because COVID, even though it hasn't fallen to a specific season yet, is still a respiratory virus that's much more easily transmitted indoors in the winter season. The next slide I want to show here is, so not cases anymore, but this is hospitalizations. And sorry, the graphs look bigger, but the numbers are much smaller on the scale, which is the more important thing to follow right now. So as I mentioned, obviously cases, most people aren't getting tested. So the official case counts are a large underestimate of what we're actually seeing in terms of cases that are out there. But the important thing is that hospitalization stays as a really solid measure, because the same, whether you would go to the hospital, you get counted whether or not you were going to get tested in the community, of course. So you can see we start that same overall trend of decreasing levels based on the last few waves. So the initial Omicron wave, we had really high hospitalizations peaking over 300. And then when you go down, the last wave, we had in the range of, I think we peaked just under 150, and then the current wave peaking even lower in the range of 100 cases in hospital at a time. So I think this severity also decreasing wave over wave is a really important thing to be aware of as well. So if we're just looking at the waves and the kind of how far apart they've been previously, we might expect that if we're following the same 90-day cycle, that we might start seeing an increase in cases again as soon as kind of mid to late September. That would follow along well. Again, these have also been driven by new subvariants arising, and so it's unclear if there's a new one that will arise and help to increase cases at that timing, or if we're going to be primarily looking at just a seasonal increase because of people going more indoors. So it's yet to see. Another thing that will be helpful, though, that I'll show next is what we saw in the Southern Hemisphere. So this is some of the data from Australia. This is first just looking at cases of influenza-like illness. So people who look sick with respiratory stuff, COVID-like symptoms. The red line is the 2022 season. It only goes up to beginning of August, sorry about the data. But I think the important thing here is to show that it started quite early. Again, this isn't specific to COVID. This is all respiratory illnesses just presenting to the emergency department with respiratory symptoms. And you can see that it was about 2 months earlier than their normal season compared to the 5-year average. Usually they have their season starting and then peaking around August and then into the beginning of September, whereas the previous one started kind of just end of April and peaked in late May, early June. And I think that's another really important thing we need to be considering for Ontario as well. So regardless of COVID-19 increases, we're probably going to see a respiratory season of all the other respiratory illnesses coming back, like influenza, like RSV particularly for children, the whole swath of things that give you runny noses throughout the respiratory season. And we're probably going to see them start a little bit earlier. Not one particular reason why is because we haven't had them for the last 2 years. If you look at our data for influenza over 2 years, we have essentially 0 cases because the measures that protect so well against COVID protect exceptionally well against all other respiratory illnesses the same way. So I think being prepared for that is really important. I'm going to go on to show here, this is specifically for influenza cases. And this is of note because you can see, compared to the 5-year average, which is the yellow, they had way, way higher influenza than they have previously. Again, no influenza really in the population for the 2 years prior, so community level immunity was probably quite low, to the point that they had even higher cases than 2017, which was a particularly bad year with poor vaccine match. The last thing here I wanted to show is just hospitalizations. And so this is hospitalizations due to influenza in particular. You can see that, again, they were quite high, higher than the 5-year average, not to the same rate, though, as in the 2017 especially bad flu season. So I think the overall picture from what we're seeing currently in Ontario, and I can stop slides now, that's basically everything interesting I had, that what we're likely to see in Ontario is an earlier starting respiratory season than we have in previous years. Probably going to see cases begin to start to increase in late September, which is a few months earlier than we normally see, and that we should be prepared for, along with COVID-19, significant amounts of additional respiratory illnesses that we see normally. So that's just kind of to set the stage with a very bleak prediction of what we're going to have in the next month or so. The next thing I'll get into is a little bit more on COVID-19 specifics. And so for COVID-19, there are a few important things about Omicron. So again, significantly more transmissible overall than we've seen previously. Important to note, it transmits in the exact same way as the previous subvariants. So it's not moving and flying through the air much farther, anything like that. The same protections that we had for the initial strain of COVID-19 still work just as well against Omicron at preventing illness. So if you go to the healthcare setting, for example, where people are wearing the appropriate PPE for their setting, we're not seeing transmission occur because of Omicron. It's really still kept tight by the measures that we have in place. But it is far more transmissible than previous variants. So any gaps in measures, you're going to see it sneak through in a way that we didn't see with previous versions. In terms of vaccination, and so there's a lot to think about here. So vaccine, we've shown that having just the 2 doses of the primary series provides okay protection against Omicron subvariants. It provides very little protection against just symptomatic transmission. So against you just getting sick at all with symptoms of COVID-19, there's very little protection if you only had 2 doses. It still provides reasonable protection against severe disease, which is far more important. Our goal is to keep people out of hospital and out of needing to get in the doctor's offices. If you have runny noses, we want to keep that from happening too if we can, but the big picture is we don't want people to go to hospital. So 2 doses is not enough anymore. 3 doses of a vaccine, so having completed your primary series and gotten a single booster, bumps both of those up significantly. It bumps up, if you've had it recently, up to 90% if you're otherwise healthy, immune competent person. In terms of severe disease, 90 to 95% we've seen. And symptomatic disease, it bumps up to about 50 to 60% reduction in just transmission of symptomatic disease. That's if you're within the first few months of having gotten your booster. Over time, that slowly wanes. The waning is starkly different based on your age and based on your medical comorbidities. If you have multiple medical conditions that decrease the function of your immune system, the waning is much more significant and happens faster. Same as if you're over the age of 70, we see waning happening a bit faster. So for that group, by 6 months out from their booster dose, we do start to see a significant drop, about 10% in protection against severe disease. If you are otherwise healthy, under the age of 60, no medical problems, if you've had 3 doses, you still have really, really good protection, even 6 months out or more, in the range of 85 to 90% against severe disease. That protection against just getting symptoms wanes and is lower, but still great protection against severe disease. So what we're expecting for the fall in terms of vaccines is we've had NACI, so the National Advisory Committee on Immunization, already come out with their statement on fall boosters generally, which is, I think, most importantly, taking away the need to count the number of doses you've had. It's just get a booster dose. Doesn't matter if you've had 1 or if you've had 3. As long as you completed the initial primary series, you should be getting a seasonal booster and that would be recommended for anybody to protect against the upcoming season of COVID-19. There's a very strong recommendation there for individuals who have medical conditions or otherwise high risk. And for the rest of the population, it's a recommendation, same as for flu, that you should get it. It helps to decrease morbidity overall. We are also expecting to have a new product of vaccine available in the fall. The dates aren't exactly clear yet, but it's a bivalent vaccine, by which we mean it covers both the original COVID and also has a specific antigen against Omicron. So that's what the important thing that we're looking at now. We only have some very early data on how well it works. It certainly is better than getting just the original product, but it's probably not game-changingly better, that it will suddenly cut transmission. We won't see COVID anymore. So really helpful to get it, particularly for those who are higher risk, absolutely. But if we're getting into the season and, again, we don't know what supply will be like, getting the vaccine that's available to you is still the most important thing. We also now have the vaccine available for kids under the age of 5. Booster doses for kids 5 to 11 will be happening pretty soon, as NACI has come out with that advice as well. So in terms of the population, we have really good coverage. The other thing about our immunity in the community is that, since the last 2 waves, the latest data we have on how many people in Ontario have actually had COVID over the course of the pandemic is that we're probably pretty close to 80% of people in Ontario have had COVID at this point. I think multiple speakers have already commented on how everybody we know has had it by now. And that's data that we've gotten from Canadian Blood Services when they look at whose blood has been donated and what has been taken. Lower for older individuals, so older adults over 70, probably closer to 50% of people. They do a much more careful work to try to not get COVID given the risks. But if we're looking at younger adults or children, 80% have already had it, which again is really important, showing that we'll have decreased morbidity and mortality from any additional waves. I'm just going to keep going until somebody forcibly stops me, so hopefully that's okay. I want to talk next a little bit about treatment for COVID-19, which is important as well. And we do have a few treatment options that are available. Mainly is Paxlovid, which is an oral medication that you would be prescribed by your healthcare provider in the community, your primary care provider, or you can go to a clinical assessment center in Ontario. That's really for people who are higher risk, who haven't been vaccinated or who have medical comorbidities, but very, very effective at decreasing severe disease from COVID-19. So if you were to take Paxlovid, which you'd have to get within 5 days of your symptoms starting, it reduces your chance of going to hospital by about 50%. So again, really strongly recommending for older adults for sure, but anybody who's younger, who hasn't had all of their vaccine doses that are recommended, or who have medical comorbidities, would still be recommended to speak to their healthcare provider if that makes sense, and if it's right for them to get it. Okay, I can't remember what else I was supposed to talk about, but I can pause there and go to questions, and happy if you want to prompt me to just keep going on.
We can do some questions and then you can go. I mean, if you have more to add, we can just keep going after, okay?
Sure.
Do have a few regarding the boosters specifically. So do you think the boosters are going to become like the flu shot? Because as you were saying, it's just become seasonal now. So is it going to become like the flu shot, or is there like an end date?
Yeah, from what we see so far, it's probably going to be something more like a flu shot. It's hard to say at this point that it'll be on a yearly basis, because again, we're still seeing new variants that come up that sometimes need to be boosted against. But we're getting closer to that seasonal approach. The fact is that with COVID-19, the vaccine does wane in how effective it is. Again, after 6 months, if you're healthy, you still have good protection against severe disease, but after a year, it does start to wane a little bit more. And so at least a yearly booster is probably what we're looking at for the future. That may be different for people who are higher risk or older. And again, it may be different depending on what variants come about or new vaccine products that come online. But at this point, we're expecting that the fall booster that people are going to be recommended at this time is probably not the last dose that's going to be recommended.
Yeah, and you were also talking about high-risk people and the new vaccine that's coming out and how it's most likely going to be a little better. So if somebody's a higher risk, what do you think if they decide they want to wait until the newer vaccine comes rather than taking the vaccine now?
Yeah, really good question. And that's something that really depends on kind of your personal circumstances, what your medical conditions are, who you live with, a few things like that. What I would say is if you are exceptionally high risk, if you're immunocompromised, if you live with someone who's over 70 with medical conditions, that it's probably not needing to wait. to get it, because again, it's unclear exactly when it will be here, and better to have protection. Again, it's the new one is going to be a little bit better, not game-changingly better in terms of what we're seeing. If you are younger, healthier, don't live with high-risk people, are unlikely to get COVID, then you're probably okay to wait. But it's these kind of questions that are probably worth discussing with your healthcare provider.
Okay, yeah, makes sense. And if somebody just got infected and they just recently started testing negative, how long do they need to wait before getting a shot, or are they unrelated?
Yeah, no, great question. Thanks for asking. So the protection that you get from having had COVID-19 lasts about 3 months. And we recommend waiting at least that 3 months until you get another dose afterwards. The rationale is, number one, you have really good protection, so it's not a rush to get another dose, but also the antibodies you have from infection can slightly dampen the effect of the vaccine. So you're better off waiting until you're further out, so you get a better response from the vaccine. And 3 months at least is what's recommended right now.
Okay, and then also with case counts, now that the majority of people are testing positive through antigen testing, and with the COVID, not many people are going to hospitals anymore, thankfully, but how do we measure case counts now? How do we know if they're too high or too low?
Yeah, it's a good question. So now that we have the same group of people who are eligible for testing, it's still a helpful comparator of the total size of a wave compared to the last one. But again, we know it's a significant underestimate of case counts as a whole. Which is why looking at things like hospitalization, ICU admission is a much more robust measure that we can use. You're going to the hospital regardless of what you're testing in this community. If you have to go to the hospital, you get tested for COVID. And if that's shown to be the cause, then we track it. And so that is a really good comparator from wave to wave of, again, how big the wave is overall and how much severe disease we're seeing. So I wouldn't put stock in the case counts anymore. I know that a lot of people still do, but it's something to back away from. And really looking at how many people are going to hospital and how many people are ending up in the ICU is far more important as a representation of the overall size and severity of a wave.
And then also, so do you think COVID is becoming like an endemic now, given that, it's not as big, at least as it used to, or?
Yeah, I mean, short answer is yes. It's not going away. It's very, very difficult to eradicate infectious diseases, depending what they're like. We've successfully done it once ever in the world, which was smallpox, and there's no more smallpox now. We were very, very close on polio. We had like 3 countries left to get through, and then the COVID pandemic hit, and now it's all over the place again. So it's not something that's ever going to go away entirely, unless we suddenly have some more significant breakthroughs in vaccine technology. And there are a lot of things being worked on, but the type of illness it is, spread respiratory disease, that it can be found still in animals as well, who can be a reservoir and potentially spread back to people, that it's so transmissible, really means that in terms of it going away entirely, that's not something that's going to happen in the near future. So same as we have flu every single year, and you could argue we've been in a flu pandemic since 1918, essentially, we're going to see COVID continuing to come year after year until there's a breakthrough in some way.
Yeah. And then we know this is about COVID, but we can't help but get a question on monkeypox.
Sure. Of course.
So monkeypox has been declared as a pandemic. Is this a public health issue, and do you anticipate it spreading into like the workplace and things like that?
Yeah, really good question. I think it's important to know what a WHO declaration of a public health emergency means, which is primarily to help allocate resources to countries and areas in need. So very different than what it meant in Ontario to declare emergency, which was, okay, we can change laws and shut things down. That's not the same thing. So the monkeypox pandemic that's been going on globally right now is primarily still just in the population of men who have sex with men. That's 99% of the cases that we've been seeing globally. And that same trend is in Ontario and Canada, where we have very, very, very few individuals who don't identify in that population. The spread in Canada has already slackened significantly. So we've been quite ahead of the game between Toronto and Montreal primarily. Huge amounts of vaccines have gone out to the at-risk population, and we've seen the spread start to stop, and it's already on the decrease. So we're doing very, very well here. Can't say the same for our neighbors to the south, obviously, where they're having a bit of trouble still. And cases will probably come from there that we'll watch. But again, the coverage here is really, really high for vaccination, which means that we're in a very good space to keep it from spreading further. So as of right now, this isn't a particular workplace risk or hazard, unless you work in a bathhouse or something, for example. But it's something that is being contained and is on the downswing. So this isn't going to become a COVID, and it's not going to get to those same proportions or be that same risk to the general public based on what we're seeing so far. Its transmission is much, much less than for COVID. So, we've already talked about to length. Everybody knows how easily COVID is transmitted. Monkeypox, you need to physically touch a person on their monkeypox lesions, and that's the way it's spread. So again, not particular workplace hazard, and it's something that is very easily mitigatable with covering up lesions.
Yeah, well, that's good to know. So if there aren't any other questions.
Here, I had another question. Sorry.
Great.
Specifically about so there's going to be, it sounds like there's going to potentially within Q4 of this year and Q1 of next year, there might be 2 different new booster shots. One, which has protection with the first strain of Omicron, and then potentially one that protects against other Omicron strains. Can you just add a little bit more clarity to that?
Sure, yeah. So what we're first expecting is a bivalent. So it covers 2 strains. It covers the original COVID-19 and Omicron. It specifically covers Omicron BA1. That's not the exact variant that's circulating right now, but it's obviously much closer to Omicron than the old stuff was. That's likely to be here within probably the next month from what we're hearing. So that's early on, and that will be hopefully something that's here in enough supply that it can be the main product we're using for fall boosters for the population. Again, in terms of how much better it is, it still a little bit remains to be seen. We know just from immunogenicity trials, which is looking at antibody levels, that the antibody levels are significantly higher using this product than using the old one against old COVID, against Omicron, against BA5 across the board. So it's likely to provide better protection, but impossible to say now how much better that will be. Again, if we have to guess based on just the antibody levels, it will be better, but not, again, game-changingly better, that you won't get sick at all from having it. But certainly still significant protection against severe disease and much better protection against getting symptoms than the current product. In terms of the other one you're alluding to, so in the United States, the FDA specifically said, we want a BA5 product because BA5 is the main variant that's circulating right now. That's something that's still being worked on by the pharmaceutical companies. We may see it this year. I think December is probably the very, very earliest that it might become available. We may or may not have BA5 as the one that's circulating in December again at that point. So it's a question of how much better or not it would be. But it is the next thing being worked on, given that it's kind of the dominant variant right now and has shown to be the most transmissible of the ones that we've seen to date. So realistically, I wouldn't be putting a huge amount of stock yet in having a new BA5 in December, January sort of thing, and more focusing on what's coming up in the season that we expect to be starting in the next month or 2.
And then there was a couple of questions that one's in the chat and one was in the question and answer box. So there seems to be this thought that the vaccines are less effective with Omicron. And I think when the vaccinations first came out, I think there was this expectation that if I get vaccinated, I'm not going to get COVID. And so as there's been a massive increase in the number of people getting Omicron, even if you are vaccinated, there's, this thought that the vaccines don't work with Omicron. So, I mean, maybe if you can comment on that.
Yeah, absolutely. So it's a little bit of a misunderstanding. So the vaccines absolutely still work against Omicron, and they remain extremely effective keeping you out of the hospital, right? So still 90+% reduction in going to hospital if you get COVID-19, which is, again, most important. Nobody wants to go to hospital or be very, very sick. Where they don't work quite as well as they did against previous variants is against just getting symptoms of COVID. So again, most of the people who are getting COVID now are having a runny nose, maybe they have a fever for a day, but they're staying at home and they're fine and they go back to work. They're not going to hospital. That's partly because Omicron itself is slightly less severe, but far more because people are vaccinated. And the vaccine again, keeps you from getting very sick. So this isn't new for the COVID vaccine. We have lots of different vaccines that work to keep you from getting very sick. The flu vaccine being a primary example. Many people still get flu if you get flu vaccine every year, but you don't end up in hospital. And the same can be said for many of our childhood vaccines. But what it does do is keep you from ending up in the hospital, needing to be on a ventilator. That's what the vaccine protects you against. And, you know, from my standpoint, if you still get a runny nose, I'm sorry, but it's not the biggest deal if you get a runny nose. We get them all the time.
And then the other question, I don't know if Mike, Louise, or Joel, you want to jump in on this. The person asked a question, essentially said, if you follow all the public health guidelines, if you are masking, if you are doing things like that, that person feels punished. Like, I'm doing all this stuff. I don't really like wearing a mask, but I'm doing it. If I'm in a workplace that requires me to wear a mask, I'm being punished. And I guess it's not, it's an observation. And I think it's one that I think probably a lot of people feel. It's not really a question, but it's something. And so I don't know if anybody has any thoughts on any of that. So
I can just make a really brief one. We can reduce that feeling if we as employers or frontline leaders make sure that if we've set expectations, we actually follow them. I think where people get very demoralized is we've got expectations and then we let our guard down, we get complacent, and we don't ask people to follow them anymore. That's where I think people really get upset, and probably, you know, rightfully so. So I really do believe it's incumbent upon all of us to, if you set your expectations, let's follow through on them. I don't mean in a harsh way, but to have consistent enforcement as well. That's one of the KVP tests. When you're at an arbitration, they also say, has this policy been consistently enforced? And so a legal answer at the back end.
And maybe just to add on to Michael's comments, I think it's a real challenge. And to the point of ensuring that the people have the comfort and that, you know, it's not being stigmatized either for or against. Because I think within the workplace, no one truly understands or knows the personal reasons why someone chooses in order to wear those masks. And so I think it's very important that we, you know, create that culture of respect for our fellow worker, for our fellow staff member, because once again, we may not understand or know their concerns, but how do we create a supportive environment that allows them to do so? So just another part of the puzzle that we continue to work with every day.
And just to echo that and add on to it, that certainly keys into the accommodation analysis, right? With respect to the workplace, considering whether or not employees do have accommodations that they require, which is why maybe visibly they're seen to be not complying with the policy, perhaps they are. So just again, echoing those comments from Dr. Moody, you know, circulating that knowledge around the workplace, but also again, not condoning employees that continue not to follow the policy and being seen to be taking steps as an employer to address non-compliance.
yeah, from an advocacy point of view, we spent a lot of time on this question in January, and I don't think it's changed. We spent a lot of time reminding members there's a difference between a workplace and a public space. And certainly, to keep it simple, we were advocating, you know, there should be the same rules in both. And obviously we've moved past that. But as an employer, you're governed in the workplace by the Occupational Health and Safety Act, and everywhere else is public sphere. But I mean, I don't know if anyone wants to jump in on that point, but certainly that adds confusion and probably makes everything more difficult as well. So.
There's one question that just came in. So do vaccinations reduce a person's ability to transmit COVID-19 to other people?
Yeah, really good question. So if you haven't been vaccinated, but you still get COVID, like you have symptoms of COVID, you test positive, you can still transmit it the same as if you didn't. It doesn't at this point seem to decrease that if you have symptoms, but the vaccine makes it much less likely that you will catch COVID and have symptoms from in the first place. And so it does decrease your ability to get COVID in the first place and therefore transmit it on to somebody else.
There's one more So it's referring to the punishment question that we had before. So the attendees asking, they were referring more towards asking people to wear a mask for 10 days after they ate lunch with a coworker who comes up positive, because people then just deny that they sat with someone to avoid mask wearing, especially if that doesn't seem to be an effective measure. Do we expect changes coming to what is expected on behalf of the employer?
So one, I mean, I'll jump in before the experts do. I've never seen that in the public health advice. So I think probably the easiest before Joel or Mike or Daniel or Louisa jumps in is let's make sure when we do things as employers, we're following the rules that exist and the best practices that exist. And I'm not sure that if you've been exposed to COVID in a close contact, the answer is going to work but wearing a mask. That is not what I've ever heard. So I think to jump in, that jumps out to me. And then probably, and I'll turn it over to the experts. Public health provides updates. When they do, as an association, we certainly make sure that we try to get it out to all of our members and all of our contacts. But public health will continue to do updates, and we all have an obligation to make sure that we're following them. But I'll turn it over to the experts now.
The experts are quiet because you're bang on.
Yeah, I just was gonna just say, that's definitely, we at MLITSD, we follow our guidelines from the colleagues at Health and Public Health. And so, we always ask people to be aware of and understand their obligations. And so that's where we would always lean on, is what does the science say? And as well as, what are we hearing from our colleagues who are the experts in this field?
Sounds good. So does anybody have any other questions or want to make any remarks? In that case, thank you all very much for joining us. We found this very important because in the summer, we got the farthest away from all the restrictions, whether it was masking or any of that. So it was a very different mentality, I felt, coming and going into the fall versus the previous fall. So we're, bringing it back to, the forefront. And as Mike said, it's not the time to let your guard down. So we hope this webinar was beneficial, and we'll share the recording and all the slides and all the policy template that we have with everybody in the post summary. Thank you all to speakers. You're great, and always very good to have you with us.